Good evening, everyone. Myself, Dr. Vinod Kaushik from IAP Digital Media Team. I will be host for today's webinar on compressive cervical myelopathy with resource person Dr. Ashish Dagar, being organized by IAP Haryana Gurugram district. The Indian Association of Physiotherapists is the oldest and the largest association representing physiotherapists in India since 1955. The IP digital media team consists of a group of physios who handle Zoom platform, webinar, live streaming, and IP profiles on social media platforms Facebook, Instagram, Twitter, LinkedIn, YouTube. Follow IAP profiles on these social media to receive notification for our events such as webinars, workshops, health camp, blood donation drive, and to know about recent updates on physiotherapy. Subscribe to IAP YouTube channel for notification of our live webinars in playlist section of this channel. Webinars are segregated into various folders on topics like orthopedics, neurology, sports and fitness, pediatric, cardiopulmonary, women's health, research, cancer, rehab, etc. for easy access. The social media links will be shared in the chat shortly. Now I will just tell about Dr. Ashish Dagar. He's a very well-renowned surgeon, consultant and head department of spine surgery, Manipal Hospital, Gurugram, MBBS, MS Orthopedics, Safdarjung Hospital in the New Delhi. He has worked fellowship in spine surgery, PGIMER Chandigarh. Now, sir is working with the Manipal Hospital. Now, I will just hand over to Dr. Ashish Dagar. Please, you can continue the webinar. Thank you.
Thank you, Dr. Vinod. And thanks for such a nice introduction. And I would like to thank IAP for giving me this opportunity to present this very interesting topic, which is compressive cervical myelopathy. So, starting with the anatomy of cervical spine. So, it is very pertaining to this topic that we understand the anatomy and physiology of how our cervical spine and its content work, so that we can understand the pathology and the treatment modalities that we can use. So there are 7 cervical vertebra, but there are 8 cervical nerve roots, and we will discuss how that is. So a typical cervical vertebra has different structures. So in the front there is vertebral body, and which has lateral to it are there are 2 special processes which contains the vertebral artery, and this is a unique feature of cervical spine. We do not get this process and foramen for in anywhere else in our spine, particularly in thoracic and lumbar spine. And these are called as foramen transversarium, and our vertebral arteries of both the sides travel through these. When we travel posterior to that, we can see there are 2 facets on each side. Then there are lamina and the spinous processes. The canal, which is in the center, is where the spinal cord lies. So this is how a typical cervical vertebra looks like. When we see in a sagittal profile, in between 2 vertebra, there is a structure called a disc, and these discs tend to be taller anteriorly as compared to the posteriorly. And because of this feature, our spine is lordotic, ranging from 20 to 40 degree in different individuals. In contrast to lumbar spine, our facet joint in cervical spine, they are in 45-degree plane when we see in a sagittal view. The implication of this is because they provide a sliding thing. There are chances of instability in cases of advanced spondylosis, and during traumatic spinal injuries also. Uh, Dislocation of cervical spine occur more frequently as compared to thoracic or lumbar spine. Our cervical spine also has one more typical structure, which is called as uncus. So uncus, you can see it is a raised portion on the lateral side when we see the spine from the front. So these two are called as uncus processes. And when these two uncus, they articulate with the vertebral body, which is cranial to it, it forms a joint which is called as uncovertebral joints or joint of Lushka. So this is also a very important structure that is different in cervical spine as compared to thoracic or lumbar spine, which do not have this Uncus process. So in between two vertebra in cervical spine, we have got five joints: two facet joint, two uncovertebral joints, and one disc in the front. So the chances of arthritis affecting the nerve roots and the spinal cord are much more in cervical spine as compared to lumbar or thoracic spine. Functionally, most of the flexion and rotation occurs in between C0, C1, and C2 level. Almost 50% of the remaining movements occur in subaxial cervical spine, starting from C3 down to C7. As we can see, the neural foramina is a foramina from where the nerve root comes out of the spinal canal. As we have seen in earlier slide also, it is in the front uncus, and the uncovertebral joint forms one of the boundaries. And arthritis of this and formation of osteophyte from uncovertebral joint can cause neural foraminal narrowing. This is in addition to what we know that the factors that affect the lumbar spine. If we see the cervical spine axially, we can see the disc is in the front, lamina in the back, spinal cord is in the center, and the nerve root which are coming out, they travel through the foramina here. So as we are discussing cervical myelopathy today, so we are usually involving the area, pathological area between A and B point. If there is pathology in the neural foramina or the point C, the patient will have radiculopathy rather than myelopathy. Now coming to the nerve roots or the spinal segments. So as we discussed, there are only 7 vertebrae, but the nerve roots are 8. So the C1 nerve root comes out in above the C1 vertebra between C0, C1, and this trend comes down. So below the C7 comes the C8, below C6 comes the C7 nerve. So we have to add one. And this is also true for the spinal cord segments also. So behind the C5 segment lies the C5 vertebra lies the C6 segment of our spinal cord. So this is very important when we are correlating with clinical examination and radiological findings. So we will discuss here what is radiculopathy and what is myelopathy. So as discussed just in the previous slide, if there is any pathology in this neural foramina, like a disc which is paracentral in location which has prolapsed, or there are osteophyte which are compressing in the neural foraminal region, patient will have radiculopathy, not myelopathy. But if the compression is in between A and B point, that is directly compressing on the cord, then patient will have myelopathy. If the patient have both, then patient will have what we call as myeloradiculopathy. Why these are important, we will discuss later in the slides. So coming to the cervical myelopathy, which is our topic. So the definition given is, it is a chronic progressive atraumatic spinal cord compression that over period of time might cause deficit or reduced function and quality of life. So it is a non-traumatic thing. So there is no history of trauma, but there is still a compression of the cord. The compression of the cord will present in form of certain signs, symptoms, and findings that we will later on discuss. Recently, to cover all the causes or the common causes of myelopathy, the term degenerative cervical myelopathy has been used. And what are the things that are covered when we use degenerative cervical myelopathy? The first and most common is the cervical spondylosis causing myelopathy. Second one is ossification of posterior longitudinal ligament or OPLL, or the ossification of the ligamentum flavum. So this is also a type of degenerative disease, but it has some genetic predispositions also. The last one is congenital anomalies like congenital stenosis of spinal canal. So degenerative cervical myelopathy, when we use this term, so it will include all these three degenerative things. Coming to the cervical spondylosis, which is one of the most common pathological causes of cervical myelopathy. And most common level involved is C5, C6 or C6, C7. But this point has to be noted. Although cervical spondylosis is the most common disease causing spondylosis, myelopathy, but a very minor fraction of patients having cervical spondylosis land up with myelopathy features because it is just a degenerative process and most of the patients remain asymptomatic and they never present to the doctor. What cervical spondylosis is, it is a degenerative process. As we grow older, our discs degenerate, the disc height reduces, the disc might bulge, the bulge usually calcifies, spine becomes unstable because of all these things, and our body reacts with formation of different osteophytes. So the complex is called as disco-osteophyte complex, which causes the main pathology. There might be degeneration of the facet joints which are behind. There might, because all these things lead to instability, which again causes ligamentum flavum hypertrophy, which although is a compensatory mechanism, but it itself causes further canal compromise. And sometimes, even if our body is trying to compensate with for all these things, there is instability in the spine, and patient might have what we call as vertebral listhesis, where one vertebra is moving forward over the inferior vertebra. Second, that we discussed is ossification of posterior longitudinal ligament, OPLL or OLF. So both of these are metaplastic processes. What that means is the calcium deposition occurs where it should not. So in OPLL, the posterior longitudinal ligament is calcified and it increases in size. In OLF, the ligamentum flavum is calcified. Because of this thing, there is a hard bony structure lying into the spinal canal, which is compressing the spinal cord. So it is a space occupying hard lesion, which is causing the vertebral compression at one or multiple levels. Usually it is multiple level disease. The third one is congenital stenosis. It is a developmental anomaly in which the cross-sectional area of the spinal canal is congenitally narrow in an individual. In such type of patients, even a simple disc protrusion or small disc bulge can cause cervical myelopathy because congenitally the area of the spinal canal is narrow in such type of patients. As we discussed earlier, there are some genetic predisposition, particularly in OPLL. So some genes which have been identified are TGF beta 3 in OPLL development, or single nucleotide polymorphism at COL6A1 and COL11A2 regions in OPLL cases. In cervical spondylosis, also MMP2 and COL9 genes have been uh, have they are discovered that these patients with cervical spondylosis who develop myelopathy have usually higher level of genetic mutation at these two levels. Coming to pathophysiology of spondylosis, myelopathy, all these factors that we have discussed lead to either dynamic or static compression on the mechanical compression on the spinal cord, which result in either direct or indirect damage to the neural or glial cells. Kyphotic deformity of our cervical spine, either degenerative or because of any other reason, cause tension on the spinal cord, and this can also directly cause chronic spinal ischemia. In addition to that, these direct damages, there might be indirect spinal cord injury because of change in vascular architecture and chronic inflammation resulting from chronic compression of spinal cord. The chronic compression of the spinal cord leads to changes in the endothelium cell function, so that the barrier between blood and the spinal cord is lost, and the inflammatory cells migrate into that area. There is increased perfusion of harmful substances into the spinal cord, which over a period of time cause indirect damage to the spinal cord. Uh, Chronic inflammation because of all these regions also cause unnatural death of the neurons, which is called as apoptosis of neurons and oligodendrocytes. All these leads to damage to the spinal cord and reduced function. So usually these patients present in fifth or sixth decade of their life, as most of the pathologies are degenerative in nature, and usually at fifth and sixth decade of our life, uh, we tend to have these degeneration of the joints. So one of the major complaints is weakness of the limbs, either the upper limb or sometimes the lower limbs also, depending upon what the level is of the compression is. This point is to be noted, pain may or may not be present. So pure myelopathy can be a painless disease also. But if patient is having some radiculopathy features, then pain becomes a important feature. Because spinal cord as such doesn't have any pain receptors, so the pain is usually a late feature when there is severe compression on the spinal cord. So this is very important, and usually this is the reason why a patient present to the doctor quite late in pure myelopathy cases. Another clinical presentation or symptom at presentation is stiffness of limbs or spasticity. Patient may present that say that my limbs are quite tight while walking. I feel that it is not easy for me to walk. I feel heaviness in my legs and all those things. Because of spasticity or because of loss of proprioception, patient may have gait imbalances also. Another symptom is difficulties in fine motor function. The function of hand and tips of the finger is lost early in the myelopathy patients. He may tell you that his handwriting has recently changed. There is clumsiness of hand. He is not able to hold on to object for long time, a period of time. He is not able to button or unbutton his or her shirt, and he is dropping the objects quite frequently. So these all things the patient might present with all these symptoms. Because of loss of proprioception or spasticity, there can be a history of increase in frequent falls recent onset, or patient may need a cane, or he may say that he do not feel confident while he is walking, and particularly in areas which requires uh, 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 which requires suppose walking on an uneven surface, patient might feel is difficult to walk there, and he might need some assistance. Sometime, as we discussed, radicular symptoms may coexist, and we then treat it as a myeloradiculopathy. In advanced cases, patient may have urinary or urgency or bladder bowel incontinence, and rarely I've seen patient presenting with frank quadriplegia with involvement of bladder and bowel in quite late diseases also. Here I would like you to differentiate between what is vertigo versus imbalance versus blackout. So in my OPD, frequently see patients of vertigo being referred to me as cases of cervical spondylosis. Uh, so we have to differentiate between vertigo and imbalance. So imbalance is a main feature of myelopathy, but vertigo is not. So usually vertigo is not present in myelopathy. And as the subset of the patient that we are dealing with are quite old, so patient might have blackouts because of other diseases also. So we need to differentiate it clinically. So blackout is when patient is saying that उनकी आंखों के आगे काला अंधेरा छा गया. So this is the what a particular line patient says. And usually it is not a case of myelopathy. Patient should undergo a cardiac evaluation, should undergo a neurological evaluation by a neurologist. Vertigo is when he says that whenever he changes position or he changes his head, the whole room spins around him. So this is what a typical vertigo symptom, what the patient says. Imbalance is when a patient says only when he is walking or standing, he is feeling wobbly. He doesn't feel confident in walking. He says that he might fall when he walks. So here we have to differentiate. Vertigo per se in myelopathy or cervical spondylosis is rarely seen, and in cases of advance. So when we can see is a vertigo in cervical spondylosis myelopathy is when you can see here, so in anatomy, we discussed the vertebral artery is passing through this foramens. When in advanced cervical spondylosis, the osteophytes are moving laterally, or they are growing laterally, and they kink vertebral artery at one or two levels. Even these osteophytes are, if even if these osteophytes are present and they are kinking one vertebral artery, even then the vertigo won't be a main feature. But when there are bilateral things, or the other vertebral artery is also compromised because of any other etiology like atherosclerosis, only then the supply to the posterior part of the brain, cerebellum, and all those things are compromised, and then patient may present vertigo and with myelopathy. So this is the only case in advanced cases of cervical spondylosis or myelopathy. Coming to physical examination of these patients, the physical exam should consist of assessment of motor strength, sensory changes, reflexes, coordination, examination of gait, and some particular signs. Starting with motor examination, patient may demonstrate gross weakness or subtle deficit depending on what the severity of myelopathy is. Or sometimes neurology motor examination can be normal also. Patient with advanced myelopathy in severe cases, because of the loss of function of the hand, so there might be atrophy of the intrinsic finger muscles of the hand and fingers. In advanced cases, what we can see, a Wartenberg finger escape sign becomes positive when we ask patient to adduct all the limbs, all the fingers. The little finger, it stays abducted. The sensory examination is also important, and it is very important to go for sensory examination because the dorsal column tracts which transmit proprioception. Proprioceptions are involved early in cases of myelopathy, and loss of proprioception is a major finding. So proprioception loss means the patient doesn't have joint sense. So he doesn't know whether his ankle joint is in flexion, extension. So this joint sense is lost. And this is one of the major reasons for having no confidence while the patient is walking, because his mind is not getting the sensation from his sensation about the position of joints from his body. Second is loss of sensation in hands and feet. But because as most of these patients are elderly and have comorbidities like diabetes mellitus and peripheral neuropathy, such type of sensory loss might be present in those cases also, and we have need to differentiate between these two. Another finding of another sensation that dorsal column takes are the vibration sense that we can test by using a 256 frequency uh, thing. Next is assessment of the gait. Because patients are spastic, patient can present with a walk which is scissoring type of gait. Because of uh, associated weakness, patient may present with unstable gait. Patient may present with circumduction of hip because of his hip flexors are weak. And all these things give a particular type of gait. And it is very important to notice this gait because progression of disease is associated with worsening of the gait, and a patient with all these things have poor recovery after surgery. So this is the case. You can typically see the gait. So he's ducting his right side. You can see because of the proximal weakness in the legs. You can see his stiffness of whole body. You can see his body is quite stiff. What else you can see is, you can see, I will just run the video again. The position of his hand. So you can see patient has lost all the intrinsic muscle of hand. He's keeping his hand in a spastic particularly position, and he is not, his grip is almost gone. He is not able to hold on to anything. And this patient luckily presented to my OPD today only. So while I was preparing this presentation. Second is when we examine, because cervical spine cord is involved, usually all the reflexes are brisk. Uh, patient where in again, because these patients are elderly and they have they might have other diseases also. Suppose a patient is having myelopathy with lumbar canal stenosis. In such type of cases, although he is having myelopathy, patient might have hyporeflexia because the nerves in the lumbar canal are compressed and the reflex arc is not complete, so that patient might have paradoxical hyporeflexia. In cases of peripheral neuropathy also, patient might have paradoxical hyporeflexia, but in a classic case, usually reflexes are quite brisk. Sorry, but we need to differentiate in such type of cases whether hyperreflexia is because of the spinal cord or from the brain lesion. To differentiate between these two, what is helpful is a what we call as jaw jerk reflex, in which if that is positive, we need to rule out any pathology of the brain. We should get an MRI of brain and involve our neurologist friends to rule out any pathology. So to do jaw jerk, we ask patient to keep his mouth slightly open and we tap here in the chin. If there is sudden jerk leading to opening of the mouth, then it is a positive. Here you can see just by tapping on the knee of the patellar tendon, we have demonstrated a hyperreflexia of knee reflex. Next is our specific signs, upper motor neuron signs that we elicit. First is Hoffman sign. So here in the same patient, you can see I have demonstrated Hoffman sign. When we put the middle finger, his great toe, the thumb adducts. This is Hoffman's positive, and this is positive on opposite side also. So this finger he has broken tendon, so that was it was not coming positive. So I changed the finger to index finger, and you can see the thumb like this. Another is inverted radial reflex. Another is inverted radial reflex. It is again sign of upper motor neuron. When we tap on the this brachioradialis, there is sudden flexion of the fingers. Next is the clonus. Ankle clonus is usually present when we suddenly dorsiflex the ankle, sudden jerk-like movements occur. Babinski is when we flicker the sole, all the fingers, they go in extension and abduction. So Romberg's is when we make patient walk in a straight line, he is not able to do walk in a straight line comfortably. He wobbles around. If patient is able to walk in a straight line comfortably, then we make him walk again on a straight line with his heel touching the toe in a straight line. If he's not able to do that maneuver, then again Romberg's is positive. Next specific sign is Lehermite sign, in which when we suddenly flex or extend the knee, patient will complain of electric or shock-like sensation traveling from his neck and going down in his arms or legs. Another physical examination test is rapid grip and release test. Usually a patient is able to do this exercise around 20 times in 10 seconds. Because of slowdown of these movements, a myelopathic patient won't be able to do this. Coming to the diagnostic imaging, once we have clinically examined the patient, we usually go for plain radiograph. And in plain AP radiograph, we usually go we look for different osteophytes which are there, whether they are going sidewise. In lateral radiograph, we see for disc height, presence of kyphosis, neutral or lordotic spine, whether there is autofusion of the vertebrae at multiple levels. We look for facetal arthropathy and any congenital stenosis. For congenital stenosis, we look for what we call as Torr-Pavlov ratio, in which we measure AP canal diameter of the AP canal diameter of the AP of the spinal canal is AP direction, and we divide it with the diameter of AP diameter of the vertebral body. If it is less than 0.8, Usually, we consider it as a case of congenital canal stenosis. Another view is when we ask patient to flex and extend his neck, and then we'll take lateral radiographs. Such radiographs are taken to look for any instability while in cases of spondylolisthesis. The diagnostic imaging of choice is obviously MRI, in which we are able to see almost all the pathologies, whether it is coming from ligamentum flavum, posterior ligamentous complex, PLL, whether it is a osteophyte which is compressing, whether it is a disc fragment. All these things we can see, and we can see the changes in spinal cord also. We can see the area of compression and all these things. And sagittal and axial T2 weighted images are the most helpful images in MRI. Uh, OPLL can easily be identified on MRI, but to see the extent, we need a NCCT also. Sometimes for preoperative planning, we might need a NCCT. In diagnosis of congenital spinal stenosis, MRI is better modality than an X-ray. And on MRI, we use spinal cord occupation score, or SCOR. If it is more than 70%, it indicates congenital stenosis. If because of any reason MRI is contraindicated, CT myelogram is to be done. There are different prognostic indicators that we look on MRI. If these are present, then chances of recovery post-surgery in patient is doubtful. If there is high signal intensity changes on T2 images in combination with low signal intensity changes on T1 images, then patient has a poorer recovery rate. High ratio of T2 signal intensity between compressed and non-compressed segment also have poor recovery rate. Greater number of high signal intensity segment on TW weighted images also have poorer recovery. There are some permanent changes in the code. If they are present on MRI, we are able to identify, just like formation of loculi or syringomyelia sort of things. Then the chances of recovery in those patients are highly unlikely. On clinical radiological examination, we need to rule out other things that can cause almost similar type of things. So subtype spinal tumors, any epidural abscess, cervical spine trauma, post-laminectomy or post-radiation kyphosis can present with such type of features. We also, again, as these patients are old age patients, any stroke, sometimes Parkinsonism disease can present with such type of things, and multiple sclerosis also. Another modality, clinical modality that we need to rule out is ALS, or amyotrophic lateral sclerosis. It is again a neurodegenerative disorder, and it is a domain of a neurologist. So if a patient is presenting to us, we need to diagnose it clearly, and if it is present, it is better to involve our neurologist friends. So ALS have particular, because it has both UMN and LMN signs. So if LMN signs are prominent, like fasciculation on clinical examination, or non-involvement of sensory, no involvement of sensory domain of our neurological system, then chances of ALS are there. And EMG and NCVs usually pick up the denervation or the element part of ALS. And usually if these things are present on NCV, then or EMG, then we should involve our neurologist friends. Now, once we have diagnosed it, now what we do is we should have some scoring system so that we are able to judge our treatment, whether conservative treatment or operative treatment. We should be able to have a objective criteria whether the patient has improved post-surgery or post-conservative management. So one of the most commonly used scales is a modified Japanese Orthopedic Association questionnaire. So this score you can see on the right side is the picture which gives in detail. So in motor dysfunction, we involve upper and lower extremities both. But for sensory dysfunction, we involve upper extremities only. And the severity of symptoms can also be judged by sphincter function. So usually the scoring is from 0 to 17. So if the score is between 15 to 17, it is categorized as mild myelopathy. Score between 12 to 14 is moderate, and a score of 0 to 11 is a severe myelopathy. So the disadvantage of this scale is because a evaluator is filling the form, and usually there is a evaluator bias in such type of things. To remove that evaluator bias, there is a what we call as patient derived version of MJO or PGMJOA is developed, in which all these things are tick marked. This they have simplified the language, and patient usually himself fill the form. So these things are the evaluator bias is removed. In addition to this disease specific score, there are some general health related quality indexes like SF36 that we can also use to evaluate our treatment outcomes. Other score is Neuric scale, which is it is not as good as JOA, but it is fairly easy to score, and because of which there is the reliability between inter and intra observer is quite high. But again, because it is a quite simplified version, the it has low sensitivity to the treatment changes. The natural history of the disease is characterized by stepwise progression because this is a slowly progressing disease. So patient might have long periods of asymptomatic, totally good life with some increase in symptom with associated acute attacks of myelopathy features. So coming to the treatment part, one of the foremost management is the first treatment to try is a non-operative treatment. Usually in mild, slow progressing myelopathy, we have found that there is no significant difference in outcome between patients who have been treated either conservatively or surgically. But if there is progression and neurological deterioration take place, then patient should turn up for surgery. The major difficulty in patients who are being managed non-operative by non-operative methods is there is no prognostic factor that we know of by seeing which we can with certainty say that this patient will progress or this patient will won't progress. So patient has to be in constant follow-up, and at the first sign of deterioration of neurology or increase in symptoms, patient should be converted from non-operative treatment to operative treatment. In moderate to severe myelopathy, there is no role of conservative management. Patient ideally should go for surgical treatment because that has got better outcomes. So for non-operative treatment, what we do is neck immobilization to provide a quiet environment for the spinal cord to heal. Lifestyle modification like reducing strain on the neck by avoiding bending forward positions of the neck that we daily do. We can use different physical modalities to relieve the symptoms during that phase. And we can give some pharmacological treatment like NSAIDs or muscle relaxants, some neuropathic drugs, all to relieve the symptoms so that till the patient is put on physiotherapy and rehabilitation, and we stabilize the symptoms and progression of the disease. It is very important to note what not to do in such type of cases. Because the cord is struck at one or 2 points in the spinal canal, traction is usually contraindicated in myelopathy cases because pulling the neck apart will stretch directly the spinal cord in between 2 points. Second is manipulation. Because in such cases, the cord is already compromised. The blood supply to cord is already low. It cannot tolerate any trauma. So forceful manipulation of any sort should be avoided in myelopathy cases. Coming to the surgical management, the goal of surgical management is definitely the cord decompression. Second is stabilization of the spine. Third is preservation and improvement of the cord vascularity. And last one is to maintain normal sagittal alignment. Absolute indication for surgery is progression of sign and symptoms, duration of symptom more than 6 months, and a compression ratio 0.54 or less, or a transverse area of cord less than 40 mm. Contraindication for surgical management include patient's inability to tolerate the physical stress of surgery if the patient is not physically fit to undergo surgery. That might be because of heart or pulmonary issues or any pathological issue which causes weightless and patient is not able to tolerate surgery. There are different surgical modalities present for this type of disease. There are different factors which need to be considered before deciding on what type of surgery we need to do. These factors include disease factors, where the disease is, and what the severity of the spinal cord compression is. Host factors including what are the comorbidities of the patient and what is the quality of the bone. Radiographic factors like alignment, whether the patient is in the cervical spine is in kyphosis, neutral alignment, or is lordotic. Whether patient is having neck pain, myelopathy, radiculopathy, or myeloradiculopathy, all these factors need to be taken. And what are the patient's expectations and what quality of life patient demands. So this is the chart that we usually follow. If the disease is 1 or 2 level only, we prefer to go from the front, giving incision in the spine, in the neck. Most of the surgery that we do is what we call as anterior cervical discectomy and fusion, or we can do ACCF, anterior cervical corpectomy and fusion. ACDF means we remove the disc in between two bones and decompress the cord. Corpectomy means we remove the vertebral body also. So we remove two discs and one vertebral body in corpectomy. If the disease is multiple level, three or more than 3 levels, then there are different factors to consider. If patient is having significant axial neck pain, then anterior surgeries are preferred because anterior fusion give a better outcome in axial neck pain. If there is no neck pain, then we need to consider whether the spine is lordotic or kyphotic. If it is kyphotic, then again anterior surgeries are considered. If there is no significant kyphosis, then we again see whether the patient is having neutral or lordotic neck. Then we go for laminoplasty. But if the patient is having neutral or mild correctable kyphosis, then we can go for laminectomy and fusion with screws. So this is a simple chart that we usually follow. So these are again other factors. I think I will skip over these things, but this chart is fairly self-explanatory. These are slightly in detail. So here I would like to just show you this. So why kyphosis of spine or lordotic nature of the spine changes our decision. Here you can see the normal curvature, lordosis of spine is maintained. So when we cut this part, which we from by the posterior surgeries, the spinal cord have space to go back. So spinal cord will fall back here. So these dotted lines denotes that we have removed this part. So if the spine is lordotic, there is tendency of cord to fall back if we cut the posterior part. But if the spine is kyphotic, even if we cut the posterior part, the spinal cord do not fall back because of the kyphotic nature of this thing, of the spinal alignment. So in such type of cases, the posterior surgeries are not useful. We need to address this kyphosis and we need to correct this kyphosis. Again, this is chart about anterior different type of surgeries. I think I would skip those. Coming to the anterior approach. So in anterior approach, we go from the front. Depending on which level we are operating, we give an incision. Usually if up to 2 levels, the incision size is hardly 4 centimeter. If the level involved are three or more than 3, then usually the incision length ranges from 7 to 10 centimeter and it becomes oblique. These looks and seems pretty difficult surgeries, but quite frankly, these are very easily done surgeries, highly minimal invasive. Blood loss is hardly 5 to 10 ml during such type of surgeries. We make a plane between esophagus and trachea on one side, and carotid artery vagus nerve on other side, and we go up to the spine and we do the thing. This is a simple structure, a simple diagram showing what we do. Once we have reached the spine, we cut the bone so that the spinal cord is free. So you can see, because the compression is in the center, we are doing is a central decompression in which we remove the disc or the vertebral body there from there. This is a simple case demonstration of a anterior case in which you can see there is multiple level compression of the spinal cord, and the spine is slightly kyphotic in nature. This is the anterior ACDF. Multiple level of disc have been removed. There are bone blocks which are placed there and fixed with the plate. The normal curvature of the cervical spine is returned. Posterior approach is when we give a midline vertical incision in the back, open, reach the bone, and then cut this portion out. Laminoplasty is one of the fairly commonly done procedure when we have to maintain mobility also. We do not fuse in this type of thing. What we do is we cut the bone on both the side and flip the posterior part open like this, so that the area of the spinal canal increases. The lifted portion can be held with wires, with some strut or plate, depending on what type of implant that we are using. Ultimate thing is the area for the spinal canal or spinal cord increases. This is an example of laminoplasty. You can see the lordotic nature of the cervical spine is preserved, and there is compression at 2 or 3 levels. So a laminoplasty works fine. This is the last case that I'm showing in which we have done anterior plus posterior fusion. You can see there is severe compression at multiple levels. There is kyphosis of the cervical spine. You can see on the X-ray also. In the first stage, the anterior corpectomy and grafting is done, and a cage and a anterior cervical plate is applied. Post first stage, you can see the status of MRI. Anterior decompression has been done. The curvature of the spine is returned. Now we go from back, cut this portion out, do laminectomy and fix it. So this is anterior plus posterior approach. I have tried to complete the topic as briefly as I could. And if you have any doubts, you can ask me questions now.
Hello, sir. Thank you
Hello.
very much, sir, for the wonderful webinar, wonderful lecture, which we have heard from you. And thanks to all the participants who have joined us. Thank you very much, sir. Thank you.